and I'm very excited to share with you some of the results from my PhD project that I've been working on for the past sort of like 9 months. But before that, let me introduce myself. So I'm Valentina.
I checked with Bernie, my counterpart in Newport, and she uses 1 to 2 vials of liquid magazine.
And I have a BSc in biomedical science and a master's in molecular medicine. Before starting my PhD, I worked for some time on a project that was funded by the Core Foundation with Jo Feary and Dr. Andre Amaral. And the project basically, we're just looking at small airways obstruction and occupational exposures in the UK Biobank cohort. And currently, I'm completing my PhD under supervision of Andre and Jo at Imperial. So before I share with you some of the results from some part of my PhD project, I just want to give you like a brief overview of my project. And then, so the title of my PhD is Chronic Airflow Obstruction in Relation to Occupational Exposures. So although tobacco smoking is the main risk factor for several chronic diseases and particularly respiratory diseases, occupational exposures also play an important role. For example, occupational lung diseases such as silicosis, asthma, or asbestosis. And in 2021, it was estimated that 90 million of disability-adjusted life years, or DALYs, were attributed to occupational exposures. So although these occupational lung diseases that I just mentioned, like silicosis, asthma, and so on, are most common, chronic obstructive pulmonary disease, or COPD, rank among the leading causes of mortality. And as COPD can occur in never smokers, it was estimated that up to 16% of COPD may be due to occupational exposures. So COPD is characterized by airway destruction and clinically manifests as respiratory symptoms, including cough, wheezing, increased sputum production, and breathlessness. And it is classically diagnosed by the presence of obstruction in the large airways through different methods, such as spirometry. However, there's increasing interest in the role that the small airways may play in the history of COPD. So what are these small airways? So small airways are those with less than 2 millimeters in diameters, and they're very susceptible to damage by inhaled particles, such as those which may be encountered in a workplace. And what these particles essentially do is they collide with the airway walls, and then these may lead to inflammation, structural changes, and increased airway resistance. So why small airways? Why am I interested in small airways? So SAO, or small airways obstruction, is known to precede emphysema changes in the lungs and reduction in traditional spirometric measures in COPD. Therefore, SAO may be an early indicator of lung disease, or may be an indicator of disease severity in those people with concurrent airflow obstruction. So even more importantly, SAO may occur in isolation without the presence of airflow obstructions. So in a previous study that we did on a large cohort data, we found associations between isolated SAO measured by different parameters and progression into chronic airflow obstruction. So he highlighted that certain SAO parameters may be used to predict airflow obstruction in the future. So really, this emphasizes that the presence of SAO may serve as an early intervention point to target, for instance, working populations at risk of developing chronic airflow obstructions, which may be even accelerated by harmful work exposures. However, much of what we know about occupational exposures and lung diseases comes from high-income countries. But over 80% of global employment is in low middle income countries, with nearly 90% being informal employment. So it was previously suggested that it was previously shown, that the highest burden of DALYs, or the disability adjusted life years, to occupational exposures was observed in the African region. And it is very likely that this problem will worsen over time due to rapid economic transformation in these countries and the high prevalence of illegal industries. And actually, people working in the informal sectors are often deprived of decent working conditions, impacting not only their respiratory health, but their overall health. This is probably due to a variety of reasons, but it may include things like more permissive or fewer policies regulating harmful exposures. So this really highlights the underrepresentation of low and middle income countries, and that there is actually a need to start addressing changes to protect working populations. So this is where my PhD starts to come in. So my PhD is really split into two large sections. So first part includes conducting a scoping review, and this is some of the findings I'll present to you today, just to look at the quantitative occupational exposure measures in different industries across LMICs or low middle income countries. Aim 2 includes to kickstart a focus group composed of occupational and respiratory health experts to determine if adaptation of certain research tools, which I'll briefly introduce later in this presentation, is needed for LMICs. And thirdly, I am interested in understanding the role that genetics may play in occupational exposures in mediating respiratory diseases. The second part of my PhD involves looking at the cross-sectional and longitudinal data of the burden of obstructive lung disease study, or the BOLD study, to first of all identify jobs and lifetime occupational exposures that may increase the risk of developing respiratory symptoms, detrimental changes in lung function, or chronic airflow obstruction. I also want to assess whether SAO and isolated SAO are associated with occupational exposures, and whether having this condition SAO and working in highly exposed settings increases the risk of developing respiratory symptoms or changes in lung function. And finally, I will also investigate the role of sex, smoking, non-occupational use of pesticide, and use of PPE, and the difference across different world regions. So let me talk to you about the BOLD study. So the BOLD study is a large cohort data set, which its initial aim was to assess the worldwide prevalence of chronic airflow obstruction, which is a characteristic of COPD, and to identify its main risk factors. So the cross-sectional data is composed of around 34,000 participants, and it has a broad coverage of world regions and ethnic groups. BOLD also has very high quality lung function measures from spirometry and lifetime occupational data available. It also has longitudinal data that is available from about 18 different sites on about 6,500 participants. So a common way to assign occupational exposures when working with these large cohort data is to use a job exposure matrix, or a GEM. So GEMs are used to assign estimates of occupational exposures based on job titles. So these jobs are usually coded using a standardized classification, such as the ISCO 88. That's just an example of one of them. And they are often developed from hygiene reports or experts' opinions, so they may either be quantitative or semi-quantitative. They could be different combinations on all the GEMs that are available. And it does have some strengths, such as it eliminates the need to assess personal exposure levels, which is very useful in large cohort studies when you need to assign occupational exposures to a lot of people. However, it does have some limitations, and they may not account for individual variation in exposures within the same job, or they may not account for geographical variability, leading to things like misclassification. So in my PhD, I would be using the Aloha Plus GEM, and this is based on experts' assessment by industrial hygienists in high-income countries, so particularly in Europe and in North America. And it was developed in 2009 to investigate occupational COPD. And it basically assigns 3 levels of exposures to 10 different agents. So agents include different type of dust, so mineral dust, biological dust, and then gas and fumes, specific types of pesticides, solvents, and metals. But it also has two big composite categories, so vapor gases, dust, and fumes, also known as VGDFs, and then all pesticides, so just a category that includes all of the pesticides together. And then he assigns 3 different levels of exposure, so 0 being none, 1 being low, and 2 being high to each agent. And then what we can do with this gen is, once we account for duration of exposure, so the time that the person has been at the specific job, then we can calculate what we said to be a lifetime cumulative exposure for each person, accounting for all of the jobs that they had for each individual agent. But really, one of the main objectives of my PhD is to determine how applicable the Aloha Plus gem is to low and middle income countries. As I said, and gems are often developed in high income countries, so it really is natural to start thinking that they may be having some problems when applying it to low and middle income countries. So, for example, are they reflecting the levels that they might encounter in work environments in LMICs? Are they reflecting the industries in LMICs, for example, new emerging industries, or the informal sector? And I think the answer at this stage is probably not very sure. So in order to start disentangling all of this and to better understand the occupational measures in LMICs, I conducted a scoping review. So the aim of my scoping review was to identify and report quantitative exposure measures in different occupational agents across any industry in LMICs. So to do this, I searched for peer review literature on the Web of Science and Medline from database inception to 1st of September of 2023. And I used text words and mesh terms, as well as the epoch filter, which is the sort of like standardized filter that is used for low and middle income countries to ensure we include any term that may refer to LMICs. And then to identify any publications with occupational exposure measures. And then I screen and extract the data using Covidence. So after doing all of this, I identified about over 8,500 papers. And then I screened most of them and removed any records that had no quantitative exposure measures, that it was not in an occupational setting, and the population was under 18 years of age, because I was interested in looking at adults. So then after I looked at the papers, about 181 papers, the main reason of why I excluded so many papers at this stage was because they didn't actually have a quantitative exposure measure, but instead they used biomarker of exposure. So I wasn't interested in that. I just wanted to look at quantitative measures that were done in different industries. So this left me with a total of 58 publications. So just briefly, just give you an overview of what the publications were like. So majority of them were cross-sectional studies. We only had 3 longitudinal and 1 case control study. The sample size across all the publications varied a lot. So anything from 6 participants all the way to nearly 2,000 of them. 25 out of the 58 publications were composed of male participants only. 30 publications reported smoking status, and 36 of them did not have any information on the use of PPE or availability of PPE. So when I looked at the publications by geographical regions, you can see that China contributed the most publications, followed by Iran, and then Tanzania. And as you may start to just pick up and see from this map, you can see that there were many countries that were not represented, and in particular in the African region and the Latin American region, we see that there seems to be quite a gap. Similarly, we see that only some countries only reported or had 1 publication, which really is not sufficient to account for multiple industries, multiple agents, or I think really obtain a realistic picture what the exposure measures in that country may be. Then I looked at the publications by different occupational sectors. So manufacturing sector had the highest number of publications, and this was mainly composed of anything like factory workers. This was followed by mining and quarrying. Primarily, it was small-scale gold mining and artisanal mining. And then the processing services included industries such as electronic waste recycling and some other factory-related work. So after looking at all of these, really the most common job titles that I found in this scope and review in these publications that I selected were factory workers with 16 publications and miners with 11 publications. So I then moved on into extracting the reported exposure levels from all the 58 publications and categorized this into different exposure agents. So just for simplicity, I'll just be sharing with you the range of the exposures that I observed for each category. And I've added the UK exposure limit at the bottom, just so you can start putting a bit into perspective of how high or how low these exposures are in comparison to what is actually allowed in like a high income setting such as the UK. So 20 publications reported exposure to mineral dust ranging from 0.03 to 801, and these were primarily collected from mining or factory-related activities. So this highest exposure that we observe here of like 801, that was reported among iron ore miners in Iran. Then this was followed by VGDS with 18 publications, and levels again had huge variations of anything from like 0.04 to like over 7,000 milligrams per meter cube. And then these were collected again, factory settings, and then some miners where they didn't account for specific mineral dust, but instead they just had an overall dust exposure, which included vapor, any dust, any gas, or any fumes that may originate from mining activities. And the highest exposure here was actually collected from miners in Burkina Faso in Africa. This was followed by biological dust. So these were farming activities and ranged from like 2 to 16. And then highest one again, it was in South Africa. Solvent exposure was collected from workers in factory, petrol station, or street workers, and it sort of ranged from like 0.4 to 256. And the highest exposure in this category was among Mexican street vendors. Metal exposure had, again, huge variation, levels ranging from 0.089 to like over nearly 5,000. And this actually, the highest exposure here was reported in an illegal e-waste area in India. And that was the only publication that we had that it was in an illegal setting. So that was quite interesting. And then we also look at particulate matter. And while particulate matter exposure is sort of like widespread in general public and may not be perceived to be an occupational exposure immediately, some occupational groups such as bus drivers, which were mainly the ones in this category, may experience prolonged and consistent exposure during their working hours, in contrast to like a passenger that may come in and go and only use the bus for a shorter amount of time. And finally, we had pesticide exposure with only one publication, which was a bit surprising given that a large proportion of the agricultural sector is in low middle income countries. So just to start and put all of these results in a nutshell. So overall, this review, we observed significant variation in occupational exposure levels, highlighting possible disparities in study methodology or regulatory frameworks, or maybe just limited resources to conduct investigations. As well, we saw a decrease in number of publications reporting exposure levels in recent years and in some geographical regions, although it may be possible that these studies have been carried out but just remain unpublished. As well, we saw that the size of the study population varied a lot across all the publications, and they were mainly comprised of men. However, this is likely to be representative of LMIC's labor market, where women are likely to assume other traditional roles such as domestic work, or they may just be working in illegal settings where there has been little to no report about it. So we also acknowledge that we had some limitations in the scoping review. For example, there was lack of publications reporting exposure levels of pesticides, particularly given that agriculture is prominent sector in LMICs. Additionally, there was no standardized exposure methodology employed, which makes it quite difficult for us to make comparisons between the studies, and the measurements may not be representative. And then only some publications reported like time-weighted averages to try and take into account the different exposure that we may have in a working pattern. As well, many studies use biomarkers of exposures, which led to a lot of my publications being excluded. And this may be due to different reasons. Could be the high cost of carrying out exposure measures. You may need a skilled workforce to carry out these, as well as there may be lack of resources, or simply that occupational research may not be a priority in certain geographical regions. So, and finally, due to the nature of the scoping review, we did not conduct any assessment of quality of the studies. Despite all of these limitations that we have, I think the review represents an initial step in understanding occupational exposure measures in LMICs, providing like valuable insights into common industries, and really emphasizing that there are quite few gaps that need further research. And so what it really is next was the next step for me. So first is to conduct some qualitative work with the focus group that I mentioned as part of one of my aims. So today I've completed an initial questionnaire with the experts that are interested in engaging within the focus group. And I look forward to meeting with them and start discussing and presenting to them what my aims are from the focus group. I will then combine the results from the scoping review and the qualitative work and meet with the Aloha Plus GEM developers, Professor Hans and Professor Rao, to try and discuss and start thinking about whether it would be useful to add maybe an extra level of exposure to the GEM that may be more representative when applying it to low and middle income countries, or if may be beneficial to add a missing job title to account for those that may be common in LMICs. So really the overall aim is to ensure that the risk of people in LMIC with harmful exposures are better assessed in future research. Thank you very much for listening to me, and I'm happy to take any questions or suggestions or comments, really.
Thank you very much, Valentina. That was an excellent presentation, very nicely executed. Any questions or comments? I have a question just while we're waiting for people. So you rightly pointed out in terms of the limitations of your scoping review, in terms of not undertaking an assessment of the quality of studies, of included studies. What was your general impression of the quality of the studies, nevertheless, even though you didn't do a formal assessment?
Yeah, well, there was a lot of variation really that we observe across all of these publications, and really the fact that there wasn't like a standardized methodology. Like you see some studies doing one specific experiment, some other studies doing another type of analysis, so it made it quite difficult to try and put into perspective like what is the right way of you measuring these exposures. So I think there were some studies that were really good, some studies that I probably didn't think about. Like I was like thinking maybe they're missing to account for these, maybe they're not taking the exposure measures properly, they may only be taking one measurement, and that was it. Like they would take one measurement at one specific point and that's it. They would be like, that's the exposure that we have, without really taking into account that the levels of exposure may vary as time goes on, and it may be different in certain like not everyone at work doing the same duty will be exposed to the same amount. So I think there really is a need to try and have that standardized approach when measuring these exposures.
Okay, thank you. I have one other question, really. You put up a map showing countries where the studies were drawn from, but there was
Yeah.
this one here. How did you account for the countries where there's been little or no studies focusing on this area? Is it a case that your scoping review wasn't sensitive enough to pick up any studies? Or
So
is there...
I think it's either that they just may be like they're not being published, or I counted for everything that included LMIC. That's why I use the epoch filter just to account for any. So that includes anywhere, any country that was LMIC. I included any other word like developing countries or like so on. And I'm not too sure whether it might be that when I excluded those with biomarkers, that they use biomarker exposures, a lot of them may be from these regions that I'm not seeing, but I think that definitely needs to be looked at.
Excellent, thank you. We look forward to you coming back in due course and presenting the qualitative results from your focus group sessions which are planned. Jo's got her hand up.
Thanks, Valentina. That was really, really good. Just Vaughan, ready to come back to your question. It may be that there's just no work being done. No studies are being done, or they're not including the qualitative works, or they're not being published. But I suspect it's just not being done. But just a comment.
Thank you. All right, a few people are asking for a copy of the recording. Just to clarify, we will make those available on the London Centre for Work and Health website in due course. All right, any other final questions before we finish up? No? Valentina, thank you once again for an excellent presentation. That was very well delivered today.
No, that's okay. Thank you very much.
No worries. So our next session, we've got Georgia Natani, a colleague of ours at the University of Southampton, who will be presenting the results from a scoping review piece of work that her and I are leading on at the moment, looking at the provision of health and wellbeing services to small and medium-sized enterprises. And that will take place on the 5th of March. So nice to see you all.
Thank you, Vaughan.
See you in a week, in a month.
Thank you.
Bye-bye.